I am disappointed in you all. You all know I'm not on TikTok, but apparently there was some story of a woman who fell in love with her psychiatrist, and apparently this is a whole 25-part series, and none of you thought to DM me or message me or comment to me about what's been going on until Tiny Blue Anthropologist stepped up and gave me the tip to take a look at this series of videos. So in the future, if you are seeing this kind of thing that falls right into my wheelhouse on TikTok or some other platform that I'm not a part of because I'm old and I'm not on all the social media platforms, please do let me know. DM me on Instagram, comment on my YouTube channel, let me know what's going on so I can do a reaction video on it. That being said, thank you for being here. Do appreciate you all supporting the channel and continuing to do so. I am going to go through not all of the videos because I scrolled through very quickly. I think there are like 25 at least of the numbered ones in this series of this woman who fell in love with her psychiatrist. I watched the first two just so I could get an idea of what I'm in for, what her presentation style is like, and if I could actually make something out of this series of videos as a reaction. So after video 2, I am going to be reacting blind to everything that she is talking about. I don't know what direction the story takes. I haven't watched other reactions to it. So you are getting my first thoughts about what is going on in this story. So I imagine we'll be talking a lot about ethics, boundaries, what therapists and other mental health professionals should be doing in these kinds of situations where a client might be attracted to you or vice versa, you might be attracted to a client. And so yeah, we'll just dive into it. I'll go through each of these videos sequentially, and there might be a part 2 depending on how long these reactions take. With that being said, please do like and subscribe. Let's dive into it.
I fell in love with my psychiatrist, and he knew, and he kept me until I had the strength to leave after 4 years. Here it is, part 1. So I decided to go back on ADHD meds after many years of being off of them. I was on them in my early 20s to help me get through college. And then I went off of them because they just weren't, like, the side effects were too much over the benefits.
So what she's talking about, this is unrelated to the ethical stuff, though being with the psychiatrist for 4 years when you're in love with them and they know, and my impression is that's not being addressed, that's definitely a problem. We'll get to that more later. But yes, a lot of people take ADHD medication, and when they enter the workforce or when they leave school, they find that the side effects, a lot of times where they feel like they're not themselves, or in worst case scenario where they're feeling like zombies and feel like they don't have any emotions at all, a lot of times those will outweigh the benefits after you leave school because you're no longer in that environment where you have to have that structured attention and focus for so many hours at a time every single day. And so even though I don't prescribe medication, I've heard this story from a lot of people, young adult clients, who are talking about that the benefits that they got from the ADHD medication that they took when they were in college or in high school just didn't seem worth it anymore now that they found work that better agrees with their temperament or the ways that they think and the ways that they process information.
But then in my late 20s, I read this book, Taking Charge of Adult ADHD, and it absolutely changed my life. For my fellow ADHDers, there's so many good things in here. And the biggest thing that I took away was that it's very important for ADHDers to be on meds. So I decided to make an appointment.
Okay, I've got questions about that. I've never read the book, so I don't know what the context is for that, but to have a blanket statement saying that adult ADHDers should be on meds, I don't find that to be particularly convincing, just in the sense that there are different situations. There are a lot of my clients, most notably the ones I think who go into the arts, whose minds have always kind of worked in that way, where the kind of scheduling and the workflow and the pacing of that kind of work just naturally works with the ways that their minds work, and they don't need the medications anymore, or it actively inhibits what they're trying to do creatively. And so for a book to say, and again, I don't know the context of that, I hope there's more nuance involved in that, but for a book to blanket statements say, adults with ADHD need to be medicated, that sounds problematic to me, and I'd be a little concerned about that without some further assessment, or at least having some questions to say like, hey, if X, Y, and Z are true, or if you're noticing this, or if you're noticing these impairments in your life, you should consider talking to a psychiatrist rather than just saying you should be medicated.
With a psychiatrist. I just Googled psychiatry in the city that I lived in, and I went with the first one that came up, and I got an appointment within a month.
That's pretty quick. I don't know exactly when this happened. She's talking about that the events are current right now, then 4 years ago. It would have been pretty hard to find a psychiatrist within a month. So the fact that she got an opening really quick and an appointment really quick, in most cases, lucky for her. In this case, it seems like maybe not so much. So we'll see how that develops.
And then I booked a 90-minute intake, and I show up to the intake, and this man is my age, and I can't help but notice that he's pretty attractive, this psychiatrist.
Okay, so that's the end of the first one. Just on the surface, nothing wrong with having a psychiatrist or a mental health professional who happens to be around the same age as you or who happens to be attractive. That happens. Me and my fellow mental health professionals have no control over that. That's just going to be a coincidence sometimes. I think what we'll see as this story develops is how we handle that as professionals is going to make a lot of difference for how that turns out ethically.
I fell in love with my psychiatrist, and he kept me anyway, part 2. So in this intake, I kind of clocked that he was attractive in my age, but when I tell you that I've had a lot of couch time in my life, a lot of therapy, I just went right into it. I trusted him enough, of course, why wouldn't I, to tell him about my childhood trauma, my daddy issues, if you will, what I had went through, all of the relationship trauma that I had. I was 6 months sober at this time, but all of the drinking and substance use I used to do. And he just listened and nodded. And that's the thing about psychiatrists, is that they're good at pretending to listen.
I feel a little attacked. I know that she's talking about psychiatrists, but yeah, sometimes what comes with the territory is that we can get to a point where we're good at pretending to listen, and it's on us as professionals. I'm talking about me as a therapist, but also all mental health professionals who go through this kind of intake process fairly regularly to actually listen. And what she talked about, opening up to him right away because she's apparently had a lot of practice in therapy or in psychiatry. That is something that I always try to point out to my clients and validate for them, that I appreciate the trust that you're putting in me, having met me maybe 45 minutes ago at best, to tell me about all of these things that you're struggling with, to be real with me about the challenges that you face and the circumstances that you're dealing with, the stressors that you're going through, and the way that your mind works. Those are all things that are deeply personal, and I always want to honor that. And then on top of that, I also want to listen for real instead of pretending to listen. So it sounds like she has some hindsight now that says that, okay, maybe he wasn't actually listening, but let's find out what's going on.
They can appear connected, but that doesn't mean that they're always connected. So I just felt really seen. And I also told him, I was like, look, I don't want to be on stimulant meds. So he listened to me, and he put me on the non-stimulant ADHD med at the lowest dose just to figure out if it was going to work for me.
That's a pretty typical process from what I understand of psychiatry, starting at a low dosage, working it into your system slowly instead of just putting you on a high dose right away, and just kind of building it up consistently so that your body can get used to the changes, because these are powerful medications. I talk about this with some of my clients, that they realize after a time that while these are small pills and it feels like sometimes it's not having an effect, because when the meds are working right, you just kind of feel normal sometimes, that we forget that these are powerful medications that are altering stuff that's going on in your brain and your body. And that's a really powerful thing that we can't take for granted. So far, he paid attention to her and her request for non-stimulant medication that seemed to be prescribed to her. And so we're gonna see what happens next.
I was in love with my psychiatrist, and he kept me anyway, part 3. So I hadn't ever seen a psychiatrist before. When I was on meds in my early 20s, I only got meds from my primary care physician. So I didn't understand how psychiatry works. So because he was figuring out my med dose, I saw him every month, and he just made me feel like I was his friend. He was really, really funny and cracked jokes, and told me he was impressed with my running that I would do. And yeah, so of course I loved the attention that I got from him. And it was...
That's an important thing to notice. that whenever we're giving feedback or compliments, as she's talking about, either he was impressed with her running or just seeing her more frequently and she was getting that attention that maybe she hadn't felt from the medical establishment and medical providers before, that can have the potential to be misconstrued. Now, I would hope for the vast majority of therapists and mental health professionals that us giving those kinds of comments and feedbacks and compliments in some way meant to inform and support the treatment, that can be misinterpreted in some ways, as I'm seeing this narrative develop, that maybe she felt like this was a different kind of connection than she had ever had with a medical professional before. And so whenever I do give feedback to my clients, I'm always trying to tie it back to some of our treatment goals. Oh, I see that you're doing this. I see that you're running regularly. And that was something that we had talked about to be able to help manage some of the difficulties that you're having either with attention or with emotions. So I see that you're putting in the effort for that, right? It's not just compliments for the sake of complimenting and being nice. So there's a subtle difference there, but there's that intentionality behind whenever I'm giving compliments, if you want to call it that, to my clients.
In my third session with him, because at this point we were all on Zoom, that I asked him, I said, hey, do you mind if I call you by your first name? And he's Pakistani, so I said his first name wrong. And he said, well, it's pronounced this, but yes, of course you can. And he seemed so smug and happy with himself. And I know that that is because that was his first sign that him pretending like we're friends was working. And
ooh, okay. So it sounds like there's a lot more story to this, that in hindsight she's seeing and reflecting on this and she's noticing some of these signs. I'm sure in the moment that she's feeling connected with this guy, that she is enjoying the time that they spend together. And in and of itself, calling somebody by their first name, at least in the therapy world, probably isn't the worst thing. I don't think it has to be an automatic red flag. Maybe it's a little different between patients and psychiatrists, but I'm not in that field, so I can't really speak to that as much. So I have plenty of clients who call me by my first name. I think what I would red flag is more so that there's been a shift in the relationship, that presumably she was previously calling him Dr. so-and-so, and now she has crossed a boundary line, or he has permitted her to cross a boundary line. And naming is very representative of the kind of relationship that you have with someone. So if you were previously calling them something and that changes, that tells you something about the nature of the relationship as well.
And to be fair to me, I had only ever been to therapy before. I didn't realize that, it's important to call your doctor last name. I mean, I did know that. I did it with all my other doctors, but it just showed that the boundaries were blurring, and he liked that. So from then on, from my third session on, I started calling him his first name. And then he just started turning up the volume on us being friendly. And he would ask me, for the first 6 sessions, he asked me, after the meds, he said, how's your bowels, bladder, and appetite? And I would say they're all normal. And then he would ask me any thoughts of harm. And apparently that's pretty common for psychiatry.
Yeah, from what I understand, that should be very common for a psychiatrist to ask you as they're checking in. So basically, as you're stepping up the medication, like you talked about, starting from a lower dosage and then gradually building it up, these are medications that affect a lot of your systems. And as you affect the nervous system and the brain, obviously that touches on other parts of your body as well. So I've heard lots of really wild side effects that you would not think are quite related to this medication that you're taking, but again, these are powerful medications. And so those seem like fairly standard questions for a psychiatrist to ask during a check-in. Like she was saying, meeting every month. Sometimes I've seen them meet every 2 weeks when you're starting a medication, just to make sure whatever side effects there are, that they are not outweighing the benefits. Again, that's kind of the proposition that you're getting with medication, is that there are side effects and the benefits have to outweigh the risks in order to make the medication worth it.
To ask those questions. And then on our 6th session, when things were really, the chemistry was starting to be there before, like, I didn't realize it. I was like, oh, this man is just friendly. And he said, I have to ask this because it's a special interest of mine. but is there any thoughts of harm? Like I was special to him. And I said, no thoughts of harm. And he didn't ever ask me a clinical question again. He stopped asking me about my bladder, bowels, and appetite, and he stopped asking me about thoughts of harm.
Wow. So when I was talking about like the deviation from the way that they addressed each other being a sign of a change in the relationship, like you're talking about, this is a massive change. When she's looking back and saying after the 6th session, and this is talking about like they were meeting once a month in the beginning to having a 4-year pseudo-professional relationship, that is a long time for him to not ask any clinical questions ever again. That is a really bold statement, and I'm really curious to hear how that plays out in the rest of their working relationship together. But she's clocking that very early on, relatively in the process of them working together, that there were some huge problems already that maybe she just didn't realize at the time. And again, this is not on her. This is on him and on us as mental health professionals to maintain those professional boundaries. That the question to ask when she asked if she could call him by his first name should probably have been, at face value, I don't have a problem with that, but I'm curious why you think you want to change that about our relationship at this point, and to really explore and process what is behind the idea of changing how you address me, because that is a significant thing and we need to think through why we are choosing to do so. And then it also would have been nice if he thought through, why am I choosing not to ask clinical questions anymore in this particular case? But clearly that did not happen.
So to me, I would just show up and he was like a therapy appointment every month. So I was seeing him every month and just gaining more and more respect for him, because he would just tell me these little things about his successes and all of the cool things that he was doing in his life.
Okay, another red flag here, which again, might not be very easy to pick out just in the moment of these sessions happening, but recognizing that she's looking back and seeing this pattern that he's talking about himself, his accomplishments, what he's doing in life, when she's supposed to be the patient or the client, that's a problem. There'll be times when I self-disclose, that's what this is called, when we're sharing parts of our real selves or our personality or our life outside of the therapy office. Again, that by itself is not a bad thing. What's important though is that it needs to be germane, it needs to be relevant, it needs to be useful for the client. It's not just, oh, I'm going to share about myself and use this time to talk about all the cool things that I'm doing. But if I share something about my experience, parenting or being a husband or becoming an adult or anything like that, it should be because it has some clinical justification or relevance or benefit to the client. And that's also one of the reasons that I don't mention my YouTube channel to my clients. That has no clinical benefit for them. I'm sure maybe if they come across some of my videos, there might be something they might be able to get from it where it would be somewhat beneficial. But at that point, I need to weigh the ethical considerations of, is this more about benefiting me in potentially getting another subscriber or a viewer versus how much it actually benefits them, which honestly probably wouldn't be that much. And it's also taking advantage of the power dynamic within the counseling relationship where I am maybe influencing them by virtue of being their counselor for something of my benefit, for my gain. So yeah, definitely a problem.
And it made me fall for him, honestly. And he was really good at listening. And I mean, he's a Pisces, right? So of course he's gonna be there. And
I don't know what that means. People who are into astrology, please let me know, because that went way over my head.
And be able to go deep with my feelings, but that doesn't mean that he wasn't extracting from them. Anyway, so I would beg him to let me see him every week. Beg him, because my therapist at the time, he was fine. You know, he wasn't a predator, but he was fine. He just wasn't doing very much for me. And so that therapist...
So that's totally fair for her to say that her therapist was not doing much at that point. And I would encourage anybody who feels like their therapist isn't doing very much to have a conversation with their therapist, to be real and say like, hey, I don't feel like I'm getting very much from these sessions. Please help me know where we are in our treatment. What are you trying to accomplish? What are we trying to work on together? Is there something that maybe I need to do differently in my time outside of therapy? Can you give me some assignments? Or is there something that needs to change about the way that we're working together because I feel like we're at a plateau? But yeah, it's absolutely another issue that she was at the point where she's saying she was begging to see him every week. Just in the terms of professional relationships, I don't think begging factors into the language of professional relationships very frequently. Like that's definitely leaning more into that unequal power dynamic that she was being taken advantage of in that way.
Retired, and I got a new therapist. And this new therapist, who is a 75-year-old woman with a PhD, she was pretty helpful. So I stopped asking my psychiatrist, begging, honestly, to be my therapist and let me see him more, right? Which also should have been a red flag. But then I started focusing on this therapist. However, I would tell the therapist how obsessed I was with my psychiatrist, and she didn't do anything about it. She just was interested. She also loved stories about my dating life, and yeah, she also was getting supply from me in her own way.
Okay, so yeah, when she's talking about extracting and getting supply, definitely the pattern of these professionals getting something from the client beyond just like the payment and the insurance and all that stuff, right? The sessions are supposed to be about the client, but it turned into maybe this guy was getting his ego boosted from this woman being interested in him, and maybe this therapist was getting a chance to live vicariously through hearing about her dating life and the drama with the psychiatrist and all of this stuff. That is not how therapy and mental health should be done. You are the client. You are getting the benefit of this. There's no side benefits or ancillary stuff for the professional, or at least there shouldn't be. And so yeah, this speaks to a complacency on the part of the professionals where, yeah, if you're a 75-year-old woman who's been in the field for a very long time, has a PhD, this is why therapists need to check in with themselves frequently, get consultation, get supervision, to be able to have a check on like how you are managing with your clients. Because at that point, like she's been saying throughout these videos, we mental health professionals are very good at pretending to listen while in fact we could be taking advantage of this process when it's supposed to be to the advantage of the client.
But that's for another part. So yeah, so I got a new therapist who actually helped me. She taught me CBT, EFT, all of these different modalities. And so I went back to just being okay with seeing Irfan once a month while he was giving me these little breadcrumbs of making me feel special, telling me about his professional achievements, telling me about how he's getting international recognition. And it worked. I was really impressed. I got a new therapist. I stopped begging my psychiatrist to see me weekly. And that is when the intermittent reinforcement started. Some sessions he'd be...
So I did not know that that trivia question that I posted would actually be relevant to this. But intermittent reinforcement is basically where you are being reinforced or rewarded at intermittent or random intervals. And this is one of the strongest patterns of reinforcement. So think like slot machines, video games, where the payout is huge, but you don't know when it's going to happen. So you're always incentivized to pull the crank one more time, to go back one more time and just see, maybe this is the time. So it sounds like he was using that behavioral principle to keep her hooked.
Warm and kind and wonderful and let me in on little parts of his life and like be vulnerable with me or pretend. Other sessions, he would be cold and clinical and detached. And you know what that did? It made me work harder in our next sessions. It did. And it started the addiction that I had to him, 100%. And
here's where I think the problem was, right? If there are techniques or counseling interventions that you can use to have a client work harder. I mean, a lot of that is what motivational interviewing is about, is increasing the amount of change talk that a client is making and talking about change, planning for something different in their lives. Nothing against that. But I think what she's saying is that she would increase her efforts to get his attention, to get those little moments of vulnerability from him, for him to tell a little bit more about himself. And that's not what we need clients putting their efforts towards in our sessions. That is not what that's about.
And he knew exactly what he was doing. This man gives lectures on trauma and attachment theory. He used his psychiatric training to manipulate me and get me hooked. And guess what? It worked. In January of 2024, I was hit by a car turning left as I was going through a green light. And it was the night before my appointment, my next appointment with my psychiatrist. So I was like, okay, I'll still be able to go to my appointment on Zoom. I'm okay. But I did make an appointment with an urgent care the next day just to get checked out. I had bruising on my abdomen and a perforated eardrum. And the provider at the urgent care said, I do not feel comfortable treating you. You need to seek emergency care now. You may be internally bleeding. But it was 11 o'clock in the morning and my appointment with my psychiatrist was at 2. So I decided that I was going to wait so I could see my psychiatrist and not have to reschedule because...
That's really concerning to hear. Again, I don't put any of the blame on her in this instance because I think she was just so deep in what the psychiatrist was doing that she wasn't able to take a step back and think clearly like clearly she's able to do now, or we as viewers are hearing this and thinking like, this is crazy. Again, as mental health professionals, our clients' well-being needs to come first. If I have a client who steps into my office and they say they just came from a car accident and may be internally bleeding and a medical professional has told them that they need to get checked out, I'm kicking them out of my office and saying, you need to go now. Like, that's about the wellness of my client at that point. And I should not be in any way encouraging a dynamic where they are compromising their own well-being in order to see me. There is no chance that I should be that important in their lives.
I was looking forward to my appointment with him so much. I look back at that time and I'm just like, oh my God, I put my own life under seeing him. I was fully addicted to him at this point. And you know what happened is that I showed up and I told him that I may be internally bleeding and he didn't stop the appointment. He didn't say, you need to take care of yourself, go get emergency care now. He let me continue and just tell him about how much I loved him and how grateful I was for him. Because that was really what most of our appointments were, is me just like pouring myself out because he was so good at the intermittent reinforcement. Yeah, I got some warmth from him that appointment. So that was January 2023. And I also told my therapist about this. She said nothing.
That's such a problem. And again, I'm never going to try to badmouth other professionals, especially, when my clients are saying, oh, this past professional didn't work for me and, you're the one who really gets me. I always try to be very careful about navigating it because that can lead into this exact dynamic that this woman is talking about. So it's not about me feeling so great that, ooh, I did this work that the other therapist couldn't, but it's putting it in context that, okay, maybe at this time this just wasn't what you were ready for, or look, they put in some framework and you all worked together to get to a point where you were able to be receptive to these changes that you're making now. So this is all in context of I am helping to build on what someone else has built with somebody else. This is not me being the hero coming in and being the one therapist that knows what they're doing, because that's not the case. That is a lot of pride and a lot of professional dishonesty in that kind of attitude. But yes, in this kind of situation, I would make an exception to tell them that, hey, your psychiatrist is not looking out for you. You need to go to the hospital now.
I got a new therapist. I stopped begging my psychiatrist. After I risked my life to see him, that's when he really started turning up the intimacy in our appointments. However, he was really smart and knew the professional lines like the back of his hand. So he would comment on my appearance, but not compliment my appearance. So I would come on screen and he would say, oh, you curled your hair. Or I would come on screen and he would say, oh, you're wearing glasses.
Well, yeah, that is pretty devious, just in the sense of he's not putting anything on paper or in a recording that could potentially be used to say that, oh, you were inappropriately complimenting your client on their physical appearance. But from what she's saying, that attention of him noticing that she had done something different would have been enough for her to interpret as, oh, he likes this. I am being noticed by him. And this little throwaway line that she said, and I think the first video where she said she shared her daddy issues, this is something that he could be playing on very heavily.
And of course I felt seen and excited that he was noticing these things about me. I didn't realize at this time that he had feelings for me too. I thought I was holding them all by myself. So I was so excited when he noticed my glasses that I ran and showed him my other pair, and he said, I prefer turtle shell glasses. So even though
Oh, okay, so I know I'm pausing a lot, but that is a huge red flag. Also, where do you get off as a psychiatrist or a therapist or a mental health professional having a personal preference for what your client is wearing? Yes, if they are unkempt or disheveled or something that reflects something about their mental state, yes, that bears commenting on or at least noting. But to say, oh, I prefer you wear this color or this design over another, huge boundary crossing that I have no business making that kind of comment.
I usually wear contacts, I'm wearing these turtle shell glasses in these videos because just in case he sees them ever, he'll see me in his favorite glasses. He did tell me he likes the turtle shell. Anyway, it was just inappropriate things like that. Little teeny things that he let me in. And all this time, my best friend is an emergency medicine physician. And she told me, she said, Kendra, one of these days, your psychiatrist, she would use his name, is going to say, I can't be your doctor anymore. I want to be with you. I want to be with you so bad. I can't be your doctor. I'll see you in 2 years.
Yeah, so the 2 years bit is that most professional organizations have a rule about how long you have to wait before you can sleep with your client or be with your client. And so apparently for psychiatry, it's about 2 years. Which of course we were taught in school, never do it. It's just not worth it. You can't trust yourself to be objective. If you're planning out 2 years in advance that you need to get rid of this client so that you can sleep with them or be with them in 2 years, just don't even go there. But what she's describing is another behavioral principle called the foot in the door phenomenon, where he's dropping these little boundary crossings so that she gets comfortable with them. She's okay. This is just our dynamic. I'm used to it. And so he keeps creeping in further and further and crossing the boundaries more and more. Eventually, the bigger boundary crossings don't feel like all that much of a difference because she's gotten used to the dynamic of what he's created.
So my best friend, who's a doctor, she picks up on stuff like that. So even she knew that our relationship was crossing boundaries and getting weird, but that became my dream, was for my psychiatrist, I almost use his name, to do that. And I told him about Brianna saying that, my best friend, who's the emergency medical doc. I told him that she would tell me that, and he just would be silent. He didn't disagree, but he didn't agree, and that was weaponized neutrality was his favorite game to play, right? He didn't disagree with Brianna telling me that my psychiatrist had feelings for me.
Yeah, that's a big thing. If a client brings that up to me, I can't be silent about that. Like, first of all, professionally, that's too much of an issue, and I can't leave that up to chance or their own interpretation. If for some reason, and I hope this has never been the case, that a client got an idea that I was attracted to them, or even that they're bringing up that they're attracted to me, that also hasn't happened either, and that's gonna be a tough conversation when that happens. I can't just let that stand and just be like, okay, moving on, let's talk about the stuff that we're actually here to talk about. No, we need to address it. We need to talk about, okay, what's going on with this? What did I say that led to this situation? What do I need to change about the way that we communicate to each other? Or what do I need to be mindful of in our future conversations so that this does not persist as a problem or an elephant in the room? And look, his neutrality says a lot too, that he's not opposed to the idea. And I'm sure being where she was emotionally with him, that was taken as good as, yep, I would like that too, but I just can't say it. But yeah, I think this is gonna be the last one that we watch, and I do appreciate that her friend did speak up. Let me see how much is left on this.
But he also didn't say that's inappropriate, let's change the subject. It was also around this time that I asked my psychiatrist if he had diagnosed me with anything other than ADHD when I had my initial diagnosis. And he said, yeah, I did. I said, oh, what did you diagnose me with? And he said, well, you had a lot of traumatic things happen to you in childhood because of your dad. And so I diagnosed you with other trauma and stressor related disorder. And that was the first little ping that I got of like, that was weird. Why would he keep that from me? I asked my, like, why wouldn't he tell me that? That seems important. He didn't tell me because he was using that information to manipulate me. He knew I had trauma and stressor disorder, and instead of helping me heal from it and telling me about it, he used it against me.
Okay, so that's the last video that we'll watch in this segment. Yes, I am going to continue, so there will be a part 2. What I will say is that yes, different therapists approach diagnosing differently, but especially if you have a psychiatrist, like they're prescribing you drugs to treat whatever they're diagnosing you with, so you should have some inkling of what you are being treated for. Therapy, it might be a little different because a lot of times I'm giving more provisional diagnoses, and I do tell my clients that this is not a final diagnosis by any stretch. These are my diagnostic impressions, and if you want to know for sure, go talk to a psychologist, go talk to a psychiatrist. But that being said, yeah, absolutely, she felt betrayed because he had been keeping this information from her, and in light of using the dynamics of that particular diagnosis to be able to manipulate her, take advantage of her emotionally. What I'll also add on to this, and I hope this is maybe a more encouraging note to end on in light of all of these crazy boundary violations and ethical problems in this case, I am glad that this woman talked to her friend who had some knowledge of what a doctor and patient relationship should look like, and who was able to give some feedback on that, even if she wasn't ready to hear it in that moment. But it sounded like it planted enough seeds for her to recognize the first cracks starting to show when she hopefully went on this journey of healing and getting over this addiction, as she calls it, to her psychiatrist. This is why I definitely advocate for people to talk specifically about their counseling process more. And that's what I'm trying to do with this channel as well, to shed some light on what counseling should look like, what the client and counselor relationship should look like, how we should behave professionally, so that we can know if there's something wrong. A lot of times people will just ask, oh, are you in counseling? Great, all right, no more questions about that. When in fact, counselors vary wildly on how ethical we are, how we work, how things go in our processes. And that's not always a bad thing because we can generally find somebody who matches for us based on our unique styles. But what that means is that it sometimes makes it difficult to recognize what is unethical and inappropriate behavior from a counselor. And so more conversations like this, more actual conversations beyond just, are you getting counseling, but what's actually going on there? What is your relationship with your therapist like? What are you talking about? What do most of your sessions revolve around? Those are questions that need to be asked so that there can be some kind of feedback on, hey, this is not okay, this is not right, whether that person's willing or able to hear that at the moment or not. So thank you all so much for sticking with me for this video. It ended up a little longer than I thought, but there's a lot to unpack in these videos, and I think we have a lot more to go through as well. So stay tuned for part 2 as well. I'm gonna try to get that done as soon as possible. Post that early for our members. So if you're not a member yet, you do have an opportunity. 99 cents a month gets you early access to a lot of my videos, and also special priority in terms of I get to see your comments in a special section, and I can respond to those directly. So thank you all so much for watching. I'll see you all next time.